right, good morning, guys. Today we're going to do a spine talk. And a lot of the information from this talk comes from a book that Roy and Don Clem and I edited called Incidental Findings in Neuroimaging and Their Management. We had we had the multiple myeloma group from MD Anderson. We had the MSK group from MD Anderson. We had UTHealth. I mean, just a ton of people collaborated on this. And what we came up with was a pretty good algorithm for working up solitary vertebral lesions. A lot of this personally comes from having worked in a spine clinic with low back pain patients for 20 years and seeing how these lesions were found and how they were worked up. If you have questions, please email me and tell me something about yourself so I can respond appropriately. My goals today are for you to have an organized approach to forming a differential diagnosis for vertebral lesions, knowing which ones are concerning, which ones are not. And then also we're going to review hopefully a bunch of cases that will typically appear on your boards. So when we look at lesions in the spine clinic and we're looking at a lumbar spine MRI, we realize that the majority of the spine and non-axial skeleton is not even being imaged. Metastatic disease is 40 to 50 times more common than a vertebral primary. And even in patients with a known primary, if you have a solitary lesion, this comes from a CT biopsy study, it had a 12% chance of being benign or due to malignancy with a different histopathology. So even if you have a primary, it's not necessarily a given that the solitary lesion is that particular pathology. Now, the management is probably going to be different in different institutions. It's going to depend upon your tools and level of clinical suspicion. So let's say you've got an interventional guy who loves to biopsy stuff and you've got a high degree of clinical suspicion because you work at MD Anderson, that you're not going to use necessarily the same algorithm that I would use in a general practice neurosurgery clinic for working up the average patient who walks in with no history with a solitary lesion. And that gets back to the predictive value of a test depends on the prevalence of the disease in the population. So if you've got a general population, your degree of suspicion and how likely these tests that I'm going to show you are to be correct depends on the population. So let's see how in the outpatient spine clinic, how do we do this? The first thing we do always look at the T1 weighted images first. Is there hyperintensity? And I think I went over last time I talked things that are bright on T1. Well, obviously fat, hemorrhage, and melanin are three things you would think about that could be in a vertebral body. Most likely, these things are going to be fat. If it's centered around a degenerative end plate, modic type 2 degenerative change. If it's a lesion that's bright on both the T1 and T2 weighted images, not fat suppressed, then hemangioma is a very good bet. Intraosseous lipomas in the axial skeleton are rare, but still possibility. And infarct more geographic with a low signal intensity on the T2 weighted image around it. Again, more uncommon in the axial skeleton. Now at MD Anderson, they would all be shouting, yeah, but wait a second, treated metastatic breast cancer can develop fat within it. Yes, that's true. But in your general outpatient clinic, you probably would know that, okay? And metastatic melanoma, we always have that on our list, but you'd be really hard-pressed to find a case of this where it showed up right on the T1 weighted image in the spine. Usually they're lytic lesions, usually there's multiple lesions, and you know the patient has metastatic melanoma. So there's an article which is very kind of famous, maybe because it's got this super catchy title, Bullseyes and Halos, Useful Discriminators of Osseous Mets. And what they were referring to was that if you look at the T1 weighted image, again, that's where we start, the bullseye sign was found to be a very specific indicator of normal hematopoietic marrow. Okay, what they meant by that is, let's say we were concerned about this lesion and maybe this patchy area. If you look closely within it, there's focal areas of high signal. This is preserved fatty marrow. So this suggests that the lesion is benign. The other thing we say, well, how low of signal, how much fat replacement, which is why the vertebral bodies are right on T1, how much fat replacement makes it concerning. When we look at the T1s, if we see signal in the lesion that is less than a normal intervertebral disc, that is more concerning. In this particular case, it isn't. And some of the increased signal of fat within the lesion is why it's not lower than the disc. This same study was done at 3T, and they found that skeletal muscle was a better thing to use, lower than skeletal muscle. On the FAT-SAT T2 weighted images, this would be the next sequence I would look at. Is the signal higher than skeletal muscle? I mean, like usually it's obvious, it's bright as a light bulb. That is concerning. You can see that this patchy area has the bullseye sign, and this is some artifact coming up from pulsation of the bowel. Overall, the lesion is certainly not super bright, so these are not lesions of concern. This is probably just patchy hematopoietic marrow. It hasn't converted completely to fatty marrow. All right, so what about the halo sign? That referred to a finding on the T2 weighted images. So here we have a lesion that's very low in signal. Is it lower than the normal intervertebral disc? Yes, it is. It is concerning in that respect. There is no evidence of fat within the lesion. On the T2 fat suppressed image, we see a halo of, you could say, edema around the lesion. So this is a concerning sign. In this particular case, they did FDG PET, which showed increased uptake in the lesion and also revealed the primary. The other way you could do this, you have this lesion, you do a CT scan, it's blastic, it's a male patient, you do a PSA and you do, and they'll probably give you the same answer. You probably get, to the same place. All right, so this is a case in the clinic where a 50-year-old comes in with lower back pain, and I'm sure what they're going to be working up was this increased degenerative disc disease and slip at this level. That's why he was there, not because of this lesion that was growing. And in 6 years, you see a lesion that's uniformly high in signal on the T1. It looked the same on the T2 weighted images, and it got larger. And then it had this halo. So the neurosurgeons are like, okay, but it has a halo. You said halos are bad. But it starts with the T1 weighted images. It's uniformly high in signal. It's fat. It's hemangioma. And oftentimes hemangiomas, because of the fat, they can suppress on fat suppression images if they're largely fat. And they often have this little falsely concerning halo of edema. And it's the angiomatous component. So vertebral hemangiomas are the most common benign lesion, 11% of the population, usually in the thoracic spine more commonly. If they're bright on the T1 and T2 weighted imaging, sometimes you won't even see them mentioned in the report. If you did a CT scan, you would see the classic polka dot sign, some areas of very low density consistent with fat. And on the sagittal recon, we see the honeycombing or corduroy pattern. So this is a typical hemangioma, imaging type typical, because it has enough fat within it to be bright on T1. And then the angiomatous components are both that and the fact that fat stays bright on the T2 weighted images makes it bright on T2. So the next imaging type that becomes a problem when you get out into practice, if you haven't already had it be a problem, are the atypical hemangiomas. They are low, they don't have enough fat within them to make them high on T1. So they're low, hypointense on T1 and hyperintense on T2. Some people say this is a bad thing to call them because atypical implies that something's wrong with it pathologically, and there isn't. It's just they don't have enough lipid to be bright on T1. In about 80% of these, the CT scans can still be suggestive. So often we'll do a CT scan. Is there any evidence of polka dot or honeycombing, coarse intrabecula, the fat within the lesion? Not we won't see it, but can we at least see coarse intrabecula and lack of destruction? The other way to do it is FDG PET. If these lesions are negative on FDG PET, then that suggests that that is benign. You can follow for a year. MRI advanced tools work well in papers that get published, which is probably why they get published. I don't know how well they work in practice in any given institution, but we could inject gadolinium and we could look at the uptake of gadolinium in the lesion, K-trans and plasma volume, which are metrics in dynamic contrast enhancement that suggest neovascularity. Are significantly different than hemangiomas. We could also do diffusion weighted imaging and look at ADC, which in metastatic disease is typically lower than an atypical hemangioma. Again, these are advanced tools that work well in papers that are published. Unfortunately, this becomes a diagnosis when there is no diagnosis, and you'll find it being used kind of like as a garbage can. So here's a classic
question.
Yeah.
We don't do much diffusion for spine. How good is it? Is there limitations? All of our spines have diffusion.
We've gotten way better. Yeah,
Is that
so you're,
standard now?
All of our spines have diffusion, okay.
Well, all of our inpatient and ER spines and many of our outpatients, all the ones done at TMC do. It's been super.
Do get.
Yeah.
Do get a standard sagittal.
And is that pretty good for access?
absolutely, yeah. So, I mean, abscess, yes, but also remember that hematomas can restrict, so,
Sure,
you know, right? So here's a 45-year-old female who had mid-thoracic pain. There was really nothing else other than this single lesion, whether it was causing her pain or not, it's highly questionable. The lesion is low in signal intensity on T1. It is lower than normal disc. It is therefore of concern. This happens a lot. So now the marrow fat is staying relatively bright on this non-fat suppressed T2 weighted image. When we suppress the fat, now suddenly this lesion appears brighter. So this is a lesion that then is indeterminate. It doesn't look terribly aggressive, but there's no degenerative disc disease at that level. Not sure what it is. So in this case, they did FDG PET. It was negative. Can't even see the lesion on the CT scan. Probably it's red marrow. Probably could be a typical hemangioma. But in any event, this gives us some security. Now, if the patient had an aggressive primary, there are primaries that do not show up on FDG PET, and perhaps somebody would want to stick a needle in it. But again, that's, you know, what is your pretest probability? In this case, no known history of malignancy. They're just going to follow with MRI, not anything with radiation. Okay, so the other type of hemangioma that you probably would most likely run into and be consulted on is called aggressive. And these are hemangiomas that have expanded bone, extended through the cortex, and present now with neurologic symptoms. So if you've got 11% of the population and only 1% of the cases do this, maybe less, why does this happen? And the only thing that's ever been shown is perhaps there's a correlation with the third trimester of pregnancy. There was a very good article that goes through all the different treatments and neurosurgical focus. I put that for you guys here. And a recent interesting article by Nicholas Theodore's group at Johns Hopkins about going through the pedicle, doing onyx embolization, and then backing it up with fixation posteriorly, because sometimes when you do alcohol embolization of these, which is a known treatment, you get collapse. And that, I'm sure it's probably why they did that. So here was a case down at the clinic that Dr. Wang saw, 45-year-old male, back pain, bilateral extremity, weakness, urinary retention. So clearly, you know, this patient's got a big problem. He's got compression of the conus, distal cord conus. So if you look at the lesion at T11 first, the lesion in the vertebral body is right on the T1, right on the T2. We see evidence of coarse intravascular. So there's really not a diagnostic dilemma there. That's a hemangioma. We had a CT scan that shows the classic honeycomb corduroy appearance and polka dot appearance. So that's clear. His question was this particular component, which appears to be now compressed, well, definitely compressing the spinal cord, but it appears to be intradural. He was concerned about that with the dural tail. Was this a collision of some sort? Was this also a meningioma? And when you look at the axial post-contrast image, you see this festooning of the dura and the central tethering with the meningo-vertebral ligament, which defines the anterior epidural space. So this is not, you know, it's not anything concerning beyond the fact that it is a hemangioma that has become aggressive, that has extended out of the cortex. Notice on the fat suppressed image how most of this hemangioma, because it's fat, is suppressing, but the angiomatous component, it has very little fat, it's lipid poor, is enhancing very densely. And I think that's the other thing that's causing that difference in appearance. Some people have said, I think Nick Theodore said in his article, that he sees these the hemangiomas that have more vascular spaces do this more often. I've never seen that written in our literature, but you know, certainly it is concerning when a lesion breaks the posterior cortex like this, that it is going to become symptomatic. So we started with a T1 weighted image, hyperintensity, yes, probably benign. No indeterminate lesion. Further workup almost always is going to be indicated. So the first thing I do is I put up the T1, T2 weighted image, fat suppressed. Go through them very carefully. Are there any additional lesions? Why? Because Met's 25-1 over primary malignancy, right? So that I'm going to always be thinking metastatic disease, multiple myeloma. So then the patients, usually we didn't work these patients up. They went to an oncologist. And I said, what do you do? She says, well, I can always tell by talking to them. So she said, if it's advanced age, heavy smoker, it's probably lung cancer, chest, abdomen, pelvic CT. Are there crab-like features, which, as you probably remember, stands for hypercalcemia, renal failure, anemia, and obviously they've got bone lesions. Then is it multiple myeloma? We don't get this kind of history as radiologists, but we do know age. So we divide it into relatively young, usually benign lesions, older, usually malignant. And again, leading the top of the list, metastatic disease, plasmacytoma, multiple myeloma. And then you can see the list of other typical lesions that would occur in younger age group versus older age group, which I'll go into some depth in these upcoming slides. So as I'm thinking about the age of the patient, I'm also thinking about position in the vertebrae. Is it centered within the body or is it coming from the posterior elements? I understand there are huge lesions that you can't tell where it came from. If it's an older adult patient, and it's both in body and extending into neural arch, I will think it's more likely coming from the body into the neural arch. If it's a younger patient, I will want to throw that into the posterior element differential diagnosis. And that will lead me to the next things I'm going to think about. So favored location in the vertebrae, vertebral body, again, Mets, myeloma, hemangioma, focal red marrow. Why? Because that's where the blood flow is. That's where the marrow is. So it makes sense that that would be the case. Chordoma, benign notochord cell tumor, because that's where the notochord remnants are in the anterior column. Histiocytosis of bone, I've never seen that lesion in posterior elements. Have you guys? Yeah, so usually, almost always vertebral body. Giant cell, I put it here, but it's actually most common in the sacrum. Giant cell is a 30, 40-year-old woman, lytic lesion in the sacrum. If it can occur, certainly in the mobile spine, more commonly in the vertebral body with involvement of the neural arch. Now, if it's posterior elements, this is where it gets interesting and fun for us in terms of making a differential diagnosis. Hint, think primary if it's in posterior elements, okay? Younger patient, primary. And most of these things are benign. Most of them are benign. So when I was a resident, for our boards, we must say osteoid, osteoma, osteoblastoma, aneurysmal bone cyst. We're just like, you must say that. And then when you do neuroradiology, you also add chondrosarc, osteochondroma, and Ewing sarcoma, simply because of the proclivity to involve and arise in the posterior elements. That's purely just stats. Okay, so indeterminate lesion, older patient, multiple lesions, Mets, multiple myeloma. Get a CT scan, is it lytic or blastic? If it's lytic, lung cancer, renal cell are your best bets in multiple myeloma. Best screening test, not a bone scan, not a bone scan. Classically negative for aggressive lytic lesions in multiple myeloma. Chest, abdomen, pelvic CT, FDG PET. If you suspect myeloma, SPET, UPET, and free serum light chains will pick up 95%. MD Anderson, until recently, was doing skeletal survey, which is like a lateral skull radiograph and x-rays of your long bones. And needless to say, you need like 50% bone destruction to show up on plain film. So that's not very good. Whole body MRI is now taking over, and I'm sure they probably already switched. Blastic lesion. What are the most typical primaries to cause blastic lesions? Prostate, breast, usually mixed. Carcinoid, transitional cell, GI primaries, medullary thyroid, and interestingly, medulloblastoma. In the cases that you can't, one of the CNS primaries that can metastasize with any degree of frequency, right, will cause a blastic lesion in most of the reports of those. Best screening test of the lesions are blastic. It's a bone scan. It's cheap, easy. All right. Posterior element lesion, younger patient, consider primary, get a CT. Why are we doing that? Because Dr. Stark and Schmidt don't want to just hear its posterior elements. They want to know exactly, how much of the pedicle involved? You know, what's the relationship to the facet joint? What all do I have to take out? We are going to confirm lytic versus blastic, which we already have suspicion based on the MRI. And we're going to look for matrix or nidus. And we're finally going to look at the margination of lytic lesions to see whether we think they're aggressive. We're going to look at the margination or transition zone. So matrix, what are we talking about when we say osteoid matrix? We're talking about this cloud-like matrix. Osteoblastomas can be lytic, purely lytic, but no matrix. They can have more chondroid looking matrix, but osteoblastoma is on the list, and osteosarcoma is high on the list. Chondroid matrix is described as rings and arcs and broken rings of calcification, classic for chondroid tumors like chondroblastoma. And then finally, this very unique diffuse sclerosis. You can see this with a chronic infection, but if you see it in the center of the vertebral body, please think of a benign nodal cord cell tumor. This is different than that polka dot coarse intravecula finding that I showed you on CT that is diagnostic for hemangioma. No matrix, very important. No matrix is important. If you think something's a plasmacytoma, multiple myeloma, or giant cell, and you see matrix, to reconsider the diagnosis because those lesions do not have a matrix. All right, important secondary findings. I'm sure there's going to be people who are going to disagree with me. I seldom find contrast enhancement to be helpful in forming my differential diagnosis. The T2 weighted images can be helpful if at the extremes. If it's dark on the intermediate to dark on the T2 weighted images, then pretty clearly anything with osteoid matrix, like osteoblastoma, osteosarcoma, osteoblastic net, the bone island, fibrous dysplasia with dense fibrous tissue, would be dark on the T2 weighted image. But the thing you might not have thought about is a giant cell tumor. And it's not known whether it's because of the hemorrhage within the tumor or whether it's fibrous elements, but oftentimes a giant cell will appear somewhat dark on T2 weighted image, which can be very useful. T2 weighted image lesions that are exceptionally bright almost always are things like chordoma, benign nodal cord cell tumor, and chondroid matrix tumors are often very bright on the T2 weighted image, and then pretty much everything else as well. So let's look at a classic case of a 65-year-old who presented with back pain. So we have a lesion on the T2 weighted image. You could think, oh, maybe this is coarse intravecula, maybe this is just a hemangioma. But we look at the T1 and there is no high signal. We cannot say that. We get a CT scan and we see that there is, obviously no coarse intravecula. There are aggressive features with destruction of cortex. There's extension into the posterior elements. So this is a lesion that is concerning. And if you will hallucinate with me for a second, and imagine that these are gyri and these are the sulci of a brain on a coronal image, like Duke, the people at Duke did. Then you come up and you will call this mini brain, which I think is very funny. This is, they considered diagnostic for a plasmacytoma in the vertebral body, and they said that you didn't even need to biopsy. I don't know whether that is being done at other institutions or not, but in any event, the way that the vertebral body is completely shelled out, lack of matrix, older patient, plasmacytoma, myeloma is very high up on the list for that in any event. So solitary lesions. So why are these multiple myeloma lesions so incredibly osteoporotic? Why is there such tremendous bone destruction? And why are path fractures so common? And it's because of activation of the rank ligand mediated bone resorption pathway. Important bone scan is classically negative, workup, as I said again, whole body MRI, you've got a number of choices. The MRI imaging presentations of myeloma are many different ways. You can see a focolytic lesion, like in that case, salt and pepper appearance of the marrow, diffuse marrow signal abnormality, diffuse osteopenia, and normal. So a completely normal MRI does not rule out myeloma. So they do bone marrow biopsies, they look for percentage plasma cells and serum markers, of course. So this is a case of Dr. Starks, 62-year-old male, felt a pop in his back and subsequent mid to lower back pain, and it occurred on a very bumpy boat ride. So I got the impression that he's in like a go fast boat and he's really getting jostled around. he had a past medical history significant for a history of GBM, glioblastoma, being treated, currently in remission. So Jessica showed me these images. I think this was after biopsy, but it really wasn't much different before biopsy. And she said, is this a traumatic compression fracture from a bad boat ride or not? So I said it's pathologic fracture until proven otherwise, but I don't think it's from his GBM. I said he's probably got another primary, like he could have metastatic disease, he could have myeloma, it could be a plasmacytoma. And she did a, I guess, transpedicular biopsy of this lesion, and it was glioblastoma. So, whoops, yeah. So I guess there you go, right? And I think that was a case report, needless to
Yeah, I
say.
think we wrote it up, right?
Yeah,
Yeah.
Shannon had operated on her for her GBM in the head and, or guy, and he had sent it to me and, yeah.
And were there, did they end up being multiple other skeletal lesions as well? Did it
I think
progress?
there was
like that,
one
or-
in the pelvis that we ended up finding. Once we, did this, I admitted him and,
Yeah.
biopsied it, and then we found a small lesion in the pelvis too.
All right, that's, so very interesting case. But I'm not going to suggest that this is always easy. When you have an acute compression fracture with a lot of bone marrow edema, this can be difficult. But the posterior bowing of the cortex is a very concerning finding, very concerning finding. Lack of any preserved normal marrow, that is a concerning finding as well. Here's a case of a classic osteoporotic compression fracture, which was discovered because the patient had trouble breathing probably from the pain with the compression fracture. It is sharply marginated. There's a retropulsed fragment, but it is not bowed. It's sharply marginated. On the MRI, there's some preservation of fat signal, which makes us feel very good about calling it a osteoporotic compression fracture. I asked one of the neurosurgeons who does a lot of kyphoplasties, what do you do? He says, I send material to path every time I do a kyphoplasty. I said, well, can you give me a case where you thought it was benign and it came back not? No, not in 30 years, but he still does it. So, so just, I guess, to cover his bases. So what does the literature say? What can we try to use if there's maintenance of at least some normal marrow signal on T1? That strongly suggests it is a benign fracture, because the theory goes a malignancy would completely replace marrow before the vertebral body would collapse. That's the theory. Again, sometimes it works, sometimes it doesn't. Preservation of the posterior cortex, non-convex border. The retropulsed fragments are sharply marginated, anterior wedging. Some of these things are obvious. If there's a big epidural foraminal paraspinous soft tissue mass, sure, it could just be edema and hematoma, but it also could be tumor. No involvement of the posterior elements. Fluid and gas within the vertebral body that has collapsed is suggested that it's benign. And are there multiple other fractures not in typical locations like thoracolumbar junction, not lesions in upper thoracic spine? Of course, that falls apart with myeloma. So we do have advanced tools to try to look at this. If you were not wanting to biopsy a patient and you were concerned about a lesion, we could inject gadolinium. We could look at DWI ADC values. But again, most of this performs really well in the literature. Not so sure how well it would perform for any given patient. So there is something that we do, which is kind of cool, I think, and that's called a post-phase imaging. So if you think about bone marrow, in any given voxel, you've got both fat and you've got water elements, right? So they go in, because they have a different processional frequency on MRI, they go in and out of phase every 1.1 millisecond, every 2.2 milliseconds on 1.5 Tesla, every 1.1 millisecond on 3T. So if you look at an image where you're in phase, both the signals are adding together, versus the image where you're out of phase, where both signals are canceling each other, if there's normal fat plus water elements in that voxel, signal will drop, and the numbers that are used are about 20%. If you don't see signal drop, then that suggests that there's not enough fat in that lesion to drop the signal. So I think that's one of the more interesting ways that people look at these lesions. And it's just, they're just basically microscopically looking for fat. Yeah.
We don't do that.
Yeah, yeah, I think MSK sometimes does that for some of their lesions, but yeah, but you're right. That is, it functions well in literature. So let's switch gears now to a 71-year-old who has a 6-month history of lower back pain and left leg pain. This is from the Methodist spine fellow. The patient had some constipation, urinary retention, normal neuro exam. So here was his sagittal T2 weighted image, and they were seeing certainly some element of central canal stenosis with bilateral posterior element hypertrophy. Was this enough to be causing his symptoms? They were not convinced. Urology saw him and they said, gosh, this is concerning to us. He's having trouble voiding. They ordered a CT of the abdomen and pelvis. And we see a very large mass. And I think if you look back closely, it was there on this. If it had been a woman, you might have thought it was going to be a uterine fibroid or something, but it's not. In any event, a large mass that is both presacral and extending into the spinal canal, arising from lower sacral segments, very bright on the T2 weighted images. So this is a classic sacral chordoma. And you imagine the fact that the most common location for chordomas to arise is not up in S1, not in the sacral ala, but rather in the lower sacral segments. And oftentimes our MRIs will stop like around S2. So it's just kind of, just keep that in mind that you're often not visualizing the most common location for which a chordoma would arise. And it is the most common primary, right? So for the residents, if you're going to put something in your brain for what a chordoma looks like, this is a good one. Lower sacral segments, right on the T2 weighted image, homogeneous enhancement. The mushroom or collar button sign is very, very suggestive of chordoma. So this would definitely be what I would want you to think of when you think of chordomas. This is a chordoma occurring at C2. Again, could it be a MET? Could it be myeloma? Sure, but this mushroom appearance should at least suggest to you that this could be a chordoma. It is the most common primary of the axial skeleton. And the incidence then is 1 in a million. So you're probably thinking that's the most common primary. So yeah, that's how rare primaries of the axial skeleton are, really, that would be the most common. They arise from a notochord remnant. Some books and papers will say that there's an equal incidence between sacrococcygeal, spheno-occipital, and vertebral. Once you're in mobile spine, cervical is the highest, followed by lumbar, thoracic, very, very rare, to the point where if you see something you think is a chordoma in thoracic spine, that would be virtually reportable. Sacrococcygeal midline lesions, usually 3rd, 4th, 5th sacral segments. Contrast that with chondrosarc, where it occurs in the sacral ala. These patients are usually males, older males. The lesions that are up at the skull base, often in cervical spine, are usually slight female predominance in younger group of patients. The only thing I want to say about the path is that this brachyury immunohistochemistry stain has been really transformative, positive in anything of notochord origin, very important. Because for our pathology friends, the differential diagnosis is often chondrosarcoma, not positive. Renal cell mets, other GU mets, not positive. So that's important. The pathologic types, classic, chondroid, having features of chondrosarcoma, and dedifferentiated, where it can lose its brachyury positivity in the highly aggressive dedifferentiated ones. This is classic path of a chordoma. Nests in cords of phycoliferous, meaning fatty-like cells, and abundant myxoid matrix, which is really the distinguishing factor between benign notochord cell tumor and chordoma. Okay, so let's talk about sacral lesions.
So, Kaye, you said the incidence of chordomas is 1 in a million. The incidence. So that means, I guess, every year in the entire country we diagnose 300.
Yeah, that's probably about right.
Seems like we see more than that. Huh?
So, well, you might.
Yeah, but I guess that's an incidence.
So I asked
number.
Richard, I said, how many spinal primaries? Right? I'm like, okay, so this is obviously anecdotal, right? So, okay, you've been practicing 30 some odd years. How many primaries have you diagnosed? Maybe 4 or 5 chordomas.
These are
One
spinal,
chondrosarc.
these are spinal chordomas.
Seen more than
not
that.
pelvic.
Correct, not
spinal,
skull,
not-
yeah.
So you have to,
That's the incidence of all chordomas.
no, you have to differentiate, so the skull-based chordomas are a lot more frequent. These are the spinal chordomas.
Mobile spine and sacrum, but you know, obviously
What
sacrum.
is cranial chordomas?
I don't know that.
I don't know the answer
I'm
to
sure
that.
it's- I'm
That's
sure
a
it's
good
higher.
question. So let's look at a sacral, let's look now higher up in the sacrum at a sacral lesion. So the first thing, when I see a sacral lesion, the first thing I want to do is look at its relationship to the SI joint. Is there any chance that this is an SI joint destructive process from like infection? So we always do that. In this case, the SI joints are normal. Look at the pelvis. Is there any chance that this is something like cervical cancer that's like creeping back into the sacrum? That would be concerning. So always look at the pelvis. In this case, neither of those things were true. It's a very lytic lesion, but you could argue that there's some sharp margination here, even sclerosis, but yet there's definitely aggressive features with cortical breakthrough posteriorly. On the T2 weighted image, the lesion is fairly low in signal, right? Which is a little unusual for metastatic disease or plasmacytoma. A lot of vigorous enhancement. So at this point, just think, what is your differential diagnosis? If it was a 60-some-odd-year-old, you'd think Mets, plasmacytoma, except for that low signal on the T2 weighted image should be somewhat disturbing to you. Chordoma, usually occurs within the lower sacral segments. And once again, this did not mushroom out of the vertebral body. So that would be not likely. Ewing sarcoma, the sharp margination, lack of a moth-eaten permeative pattern would argue against Ewing's. And so we end up down at giant cell and chondrosarc. And chondrosarcomas usually have a chondrotic matrix, and this has no matrix. So this has everything going for it for a giant cell tumor. The most common demographic would be like a 30, 40-year-old woman.
So the incidence is 1%, one per million, including cranial. So over a 14-year interval, they diagnosed 3,600 cases in 14 years.
Yeah.
That's surprising, right? I mean,
It's surprising,
we seem
yeah.
to see
I
them at
agree.
least once or twice a month in some form, but it should only be 300 a year in the country.
Yeah, so you're concentrating.
Somehow.
Yeah.
Right, Feroz, you see one at least? Once a month or what?
No,
No?
we probably take out like 3 years.
Yeah.
It's not that.
It's still a lot more than you think it should be.
Yeah, well, good to know.
Yeah, very interesting.
You can
So
tell
out
our
in-
patients are 1 in a million.
Out in practice, if you were out in private practice, you probably would see maybe 5 or 6 in 30 years. All right, so giant cell tumor, second most common primary of the sacrum. What's number 1? It's chordoma. Sacral lesions are usually going to be Mets, myeloma, plasmacytoma, 93%. Slight female predominance. Again, they can cross the SI joint, which I think is kind of interesting. No matrix. That's really, really important here. Lytic with a sharp cortical, it may have cortical breakthrough, but lytic, but with a sharp transition zone, low signal in the T2 weighted image. And it is one of the lesions that can have secondary aneurysmal bone cyst formation. I don't want to say a lot about this idea that giant cells may be malignant, but it is kind of important that there was these weird reports of metastases that spontaneously regress with patients that have giant cell. And this sounds like a trick question. What's the malignant cell in giant cell tumor? It's not the giant cell, interestingly enough. It's a stromal cell that's producing rank ligand, which is activating these osteoclasts and causing them to go crazy. And that's why there's no matrix. It's giant cells that are being turned on to resorb bone. What additional non-spine imaging is needed if you diagnose somebody with a giant cell tumor? And the answer is chest CT, interestingly. 9% will present with metastatic disease to the lung. Yeah, kind of interesting. So one of the treatments now for unresectable giant cell is denosumab, which is a monoclonal antibody against the rank ligand. And there's some reports suggesting that these people that have giant cell treated like this go on to develop spindle cell sarcoma. So obviously it's concerning. Some reports say that no, there's no increased incidence. So the question becomes, did the giant cell become malignant, or was there an underlying malignancy the whole time? and it was misdiagnosed with a sampling error. When I was a resident, we were told you don't radiate giant cell tumors because they can become sarcomas. And then it came out, well, maybe it's because they were sarcomas to begin with the whole time, because there's this thing called a giant cell rich osteosarcoma. What I took home from all of that as a radiologist is that in a true giant cell tumor, I should not see any matrix, should not have any matrix. If I see matrix in something that they're calling a giant cell tumor, then I might say, what's causing that matrix? Right? Go back and look at that. Because there are other lesions that can simply have giant cells. So here's a 22-year-old male with upper thoracic back pain. And I would argue to you, we can say this is a young patient, obviously, and the lesion is arising somewhat from posterior elements, but clearly going into the vertebral body. So you think about our differential diagnosis in your head: osteoid, osteoma, osteoblastoma, aneurysmal bone cyst. It's obviously not an osteoid osteoma. There's no nidus, way too big. Could it be an osteoblastoma? Sure, they could have lytic lesions. Aneurysmal bone cyst, possibly. And in any event, we're going to definitely head towards an MRI. And the radiologist at this point, Jennifer's breathing a big sigh of relief, because now she can say, this looks like an aneurysmal bone cyst. Look at all of these fluid levels. These high signal in T1 shows that there's some blood fluid levels in this tumor. This is a much larger one. Again, you can start to see some of the blood fluid levels already. Notice the sharp margination of the aneurysmal bone cyst, not clearly distinguished from the normal adjacent marrow. Tons of blood fluid levels in this particular case. It was aneurysmal bone cyst. So the majority of patients are less than 20 years old. They often arise in the neural arch, but 70–90% extend into vertebral body. The majority in young patients are primary, but always keep in your mind, and I'm sure that all the radiologists know this, but you can have secondary ABC changes of other tumors. So if you see a lot of other soft tissue mass that's not ABC-like, consider the possibility it's a giant cell, osteoblastoma, fibrous dysplasia, and even a telangiectatic osteosarcoma can have secondary ABC changes. So those are the things that we kind of worry about. This is another classic case. 16-year-old male, dull, aching neck pain, awakens him at night.
So we have a case, not here, that we called, we called ABC. We didn't do a bone scan, and that grew and grew, and then in the bone scan, it was an osteosarcoma. So,
oh wow,
I think doing bone scans for these, if they're growing, it's good. And at RSNA, we get it all the time as a differential.
that's really good. That's yeah. So this is more than just a cursory warning that you can really get burned on this. This is a classic case for the residents. You might get this from the history alone. Dull aching neck pain, 16-year-old wakens him at night. On this image, you can't really tell. It's a parasagittal image. Something's going on in posterior elements. It looks like there's a lot of edema and involvement of the facet joint. I might even be concerned, but there's no fluid in the facet joint. But you might have even wondered, is this an infection perhaps? Kind of odd, right? So post-GAD, tons of enhancement. The lamina going into vertebral body, tons of enhancement around it. So it looks like there's something very aggressive or concerning going on. Posterior element, get CT scan. Right? So on the CT scan, it becomes much clearer that there is a lesion with a central calcified nidus that's in the superior articulating process of this vertebral body. This is a classic osteoid osteoma. Classic, okay. They can present with painful scoliosis. Sometimes they're hard to find, these lesions, so you could consider doing a bone scan. They will light up like a light bulb with a bone scan. Osteoid osteoma, the nidus is less than 1.5. Osteoblastoma, which some people consider pathologically the same, greater than 1.5 centimeters. But if you look at the natural history, they're very different, very different. 75% of osteoid osteomas, posterior elements, 10 to 20 years old, painful scoliosis, responsive to nonsteroidals. No response to nonsteroidals with osteoblastoma because they do not have the progesterones. Nocturnal exacerbation, no nocturnal exacerbation, does not progress, unlimited growth potential with the osteoblastoma. And then here I put down a differential diagnosis for you, even though when you see this, almost virtually no differential diagnosis. I used to have osteoid osteoma does not convert to osteoblastoma, period. And then they came out with one case report. So usually not, but don't think of these as being on a growth continuum. That is rare. That's like a case report. And finally, imaging distinction between aggressive osteoblastoma and osteosarcoma may not be possible. So if you've got a lytic lesion, you're going to end up biopsying it, and it's going to come down to path. So here, this is the only case I have of an osteoblastoma. I found this one in the literature, and I'm just pointing out what's called flare. This is called the flare response associated with e.g. osteoid osteoma, eosinophilic myeloma, where you look on the MRI, it looks way bigger, way more concerning. With all this edema enhancement within bone marrow that is going to be normal once this nidus is treated. Okay, so that's kind of interesting. Classic boards case, 50-year-old male, mid-thoracic back pain. Okay, so there are a couple of things in the differential diagnosis, osteochondroma versus osteosarcoma. This rings and broken rings of calcification is chondroid matrix. It's thoracic region. It's involving, probably came from this rib head. If you look at the non-calcified parts that are dark, well, the calcified parts are dark on T2, but if you look at the areas that don't have matrix, they're very bright on the T2 weighted image. This is classic for a cartilaginous tumor, to be very bright like that. So chondrosarcoma is almost certainly the diagnosis. This much soft tissue abnormality makes it not compatible with a osteochondroma, not compatible because the amount of soft tissue abnormality, back pain, growth, all of those things suggest that this is not just an osteochondroma. Another chondrosarc that Nancy Fishbein from Stanford gave me. I don't even have a CT on it because they just biopsied it straight away. But again, I think it's nice because it shows how high the signal is and this massive appearance of this lesion in the posterior elements, thoracic spine. Chondrosarcs, mid-age group, thoracic spine most common. And they often are huge when they present because they're growing so very slowly, can be often quite large. They may be primary or secondary to malignant transformation of an osteochondroma, which may be what happened in that rib head case. So I want to definitely show you guys this case because this is very interesting. This is also from Stanford. So it's a 30-year-old female and it's posterior element. So we run through our differential diagnosis, the things that you might think would fit would be things like Ewing's, osteoblastoma. You know, those would be the two things I would think about. It looks way too extensive to be obviously osteoid osteoma, and there's no fluid levels to suggest aneurysmal bone cyst. So of course, posterior elements, get a CT scan. What do we see on the CT? We see that the spinous process is not really expanded, but it's eaten. It's block eaten. This is permeative. That is what permeative, wide transition zone, very aggressive tumors do that. So we think small blue cell tumor. This should have been Ewing sarcoma is what it should have been statistically, but it was not. It was a B-cell lymphoma, so still small cell blue cell, right? So I guess we're close. This is the only case that I have of an osteoblastoma, again from the literature. And they thought it was an osteoblastoma, I should say. And then they went and biopsied it, and it turned out to be Ewing's. And again, this like aggressive appearance, osteoblastoma can have that, but this becomes a pathology issue. It's for them to decide whether is this Ewing's, is it lymphoma, is it super aggressive osteoblastoma? But we must suggest that it is an aggressive lesion based on the permeative appearance. So Ewing cell sarcoma more commonly in the pelvis, if it's spinal, often will present with constitutional symptoms like fever, increased sed rate, and weight loss. It's one of the lesions that can present as vertebral plana. And this is my classic Ewing slide. I don't have an MRI on it, but this is just a classic. And what this is showing is that if you took a Sharpie and you tried to outline where the tumor was, you'd have a hard time doing that. Maybe we should include this. I don't know, should we include this? So this is poor margination. This is permeative. The cortex is disrupted, and if you look at like normal fat planes around traversing nerve root, gone on this side. Fat planes in the paraspinous region, gone on this side. So the amount of soft tissue mass relative to what the CT is showing us, I call this like the tip of the iceberg. It's tip of the iceberg, and this is classic for Ewing's, classic for Ewing sarcoma. Any words about just bad, bad, bad? So yeah, when you see permeative bone destruction, large soft tissue mass, small blue cells percolating out through the vertebrae, that is concerning. So the key messages are solitary lesions in older patients are more frequently malignant. Statistically, Mets and multiple myeloma are your best bet. Chordoma is the most frequent primary. If you have a posterior element lesion in a younger patient, run through that differential I gave you of at least like 5 things in your head. Don't say them on the exam, because osteoid osteoma doesn't look anything like a chondrosarcoma, but you just run through that. Posterior element, osteoid osteoma, aneurysmal megacyst, osteoblastoma, osteochondroma, Ewing's, chondrosarcoma. Run through those 6 things in your head because of the proclivity to present with posterior elements in the posterior elements first. When in doubt, but consideration for malignancy is low. Like Roy said, consider other tests like bone scans. Consider if you can't find the lesion, painful scoliosis, bone scan, great test. FDG PET, if it's an atypical lesion and you don't have a lot of, you don't want to follow this and be proven that it is something more serious later on, to have at least a negative FDG PET might make you feel better. So I think that's about all. I want to leave time for a few questions. Any questions?
I've never seen a bone infarct. What is that? You had that on your.
I have only seen that in the sacral ala in one patient who was on steroids and had some other sort of blood clotting disorder. And I saw geographic sacral ala, but in vertebral body, I've seen it maybe a couple of times.
Do we have
Sickle cell.
Sickle cell.
We've
Sickle
had-
cell.
Yeah.
We've had 3 cases of post-chemotherapy bone infarcts here in the lymphoma patients. I'll send them to you.
Yeah, that's.
They are, you will see a geographic pattern. It's kind of very typical.
Yeah, I wish I had brought my, I didn't even think to bring it, but yeah, the case that we had, the central part of the lesion is high signal in the T1 weighted image. But what makes it look odd to you is there'll be like this geographic low signal on the T2 outline around the lesion. And that kind of helps you say, that leads you to believe that it's a bone infarct.
So could it be in those cases, Roy, that it was actually lymphoma in the bone and the chemotherapy killed it? Because it's not really an infarct, but it's really the effect.
I think that,
Yeah.
because what the literature says is that because of certain chemotherapeutic agents and the way it's distributed could be the vascularity to the bone that could be happening. And they didn't have any bone marrow changes in the PET before. It seems to be related specifically to but it could be,
It's a little bit like avascular necrosis of the hip.
Yes.
Yeah.
But it's different.
It's probably the same
So
entity.
one thing is
on
an avascular
steroids,
necrosis.
immunosuppressive therapy.
So Kimmel disease is
Appearance
different
setting.
than, they have different presentations. Like vascular necrosis of the spine is different than bone infarct. The bone, there are 2 different diseases. There's Kimmel's disease, which is different, which is a vascular, there are 2 different scenarios. And they look very different, but I'll be glad to share. I have collected a couple of those cases.
Great, thank you.
So thank you, Kate.
All right.
This is wonderful as always.